This podcast provides general information, not a substitute for professional medical advice. Please consult your physician for personalized guidance.
Hello, everyone. Welcome to Psych Rounds, a resident-run educational psychiatry podcast. Today, we are discussing our introduction to attention deficit hyperactivity disorder, or ADHD. I'm Dr. Bradley Miller, taking the lead today since Dr. Hewitt is out, but I'm joined, as usual, by Dr. Larry Wang. Now, ADHD is largely learned past the first year of residency, so while Dr. Wang has covered ADHD during child and adolescent rotations, us interns have significantly less clinical experience in this area. Thankfully, today is also acting as a guest episode with someone much more familiar with ADHD, so that will give us a better perspective. Joining us is Dr. Nikita Roy, a psychiatrist who is fellowship trained in child and adolescent psychiatry at the University of Michigan, and the director of the Child and Adolescent Psychiatry Fellowship Program at Central Michigan University. So she has a lot of experience with ADHD and also with educating students and residents. Thanks so much for joining us, Dr. Roy. Do you have anything else to add?
Happy to be here. Hopefully I can answer all of your questions.
All right. Well, I think the best place to start is very simply, how would you conceptualize or articulate ADHD to a learner? There's a lot of misinformation colloquially and on social media with what it entails. So what exactly is ADHD?
So the best way that I would describe ADHD, I think you have your psychiatric diagnosis, by the book diagnosis, and then you have your maybe more casually understood diagnosis of ADHD. But how I view it and how I describe it to others really would be that this is a disorder, a neurodevelopmental disorder. So I understand that as a disorder from early childhood or maybe even from birth. And you have a disruption in the way that you are able to focus, the way that you are able to stay on task, your ability to complete tasks. And there are different hypotheses as to why there is this difference in attention and thinking. And how you want to understand ADHD based on these different hypotheses is kind of left up for interpretation because there yet is no one specific hypothesis that has been absolutely confirmed.
Cool. That's a good way to start. So you talked about different ways of interpreting what ADHD does. So I wanted to quickly touch on the DSM and some of the DSM criteria. So I don't want to go over all the criteria. That's going to take a long time and might put some of our listeners to sleep. But a few that stand out to me include these ones. So, quote, often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort, unquote. Another one is, quote, often has difficulty sustaining attention in tasks or play activities. So these can include things like difficulty remaining focused on lectures, conversations, or lengthy reading. So when I think about stuff like this, I think about myself sometimes. So if I'm watching a lot of bad TV, sitting on my couch all weekend, eating junk food, I feel like I might even meet some of this criteria. So how is ADHD, the diagnosis, different from someone who's just being inattentive or hyperactive at baseline?
So I think you have to look at ADHD in a context outside of just individual symptoms. And quite honestly, not to sidebar, but I think it is a little bit of a problem at large where symptoms are equating to diagnoses in the general population, which I don't think is always necessarily accurate. So those that you just described, Dr. Wang, those are specific symptoms within the overall diagnostic criteria. They can't be looked at in isolation, and they can't be looked at time specifically. They have to be looked at within the broader spectrum of development, impact on functioning, duration of the symptom, and in context of the other criteria that are needed to come to a diagnosis of ADHD. So I think to a degree, everybody over their lifespan will experience symptoms because a lot of these symptoms are even neurodevelopmentally normal. What you see in hyperactivity and ability to concentrate in a 2-year-old looks very different than what you expect in a 14-year-old. So you have to take the developmental aspect into consideration as well. But I think to summarize, essentially, those are symptoms and you have to view those in a context and as a whole with all the other diagnostic criteria as well.
So it sounds like we're taking a lot more of a global perspective with regards to like severity of symptoms and time courses.
Absolutely.
Okay. So looking at the epidemiology of ADHD, so prevalence is looking somewhere between 5 to 9% for children and 3 to 5% for adults. And estimates that I saw were suggesting that the ratio is about 2 to 1 of male to female. However, this number appears to have been decreasing over time, with older estimates being higher. So with regards to subtypes, there's the inattentive predominant, hyperactive predominant, and combined. So I was wondering, Dr. Roy, if you could talk about the differences between how these present, gender differences between them, or clinical pearls you might have when looking at those, whether it's for diagnosis or treatment.
Sure. So the subtypes of ADHD being inattentive type, combined type, or hyperactive type, that's relatively newer to the DSM-5. Those specific subtypes were not present in the DSM-4. And I think they do a better job of kind of helping us understand how the symptoms present and how you do see some of the differences between males versus females. But essentially, your inattentive type, you are going to have the criteria that are needed to meet for the inattentive symptoms. So the DSM in the diagnosis of ADHD requires that you have 6 symptoms between inattention, hyperactivity, and impulsivity. And if you have all your symptoms fall under inattention only, then you would be under the subtype of ADHD inattentive type. If you have symptoms across the spectrum, it will be combined. If your symptoms fall under just impulsive or hyperactive, then you'll have the hyperactive type. So when it comes to genders, you see a much sort of higher percentage of combined or hyperactive type in males. You see females tend to be much more frequently diagnosed with inattentive type. And this leads to a very different presentation, a very different time frame of diagnoses for males versus females if you have inattentive type. Inattentive type ADHD, it's a lot easier to miss. If you have a kid who's sitting pretty quietly in the back of the classroom, staring off, doodling, not paying attention, but also not very disruptive, a teacher or a parent might just chalk it up to, nothing big deal. Maybe they just don't understand the material very well. Maybe they just need, extra time. They need to be tutored. It sometimes gets more chalked up to maybe they're not that smart. But now if you have a kid who's blurting out answers, getting out of their seat, disrupting other people, teachers, parents, others, they notice that right away and they're quick to say, maybe this child needs to be evaluated for something. So hyperactive or combined type ADHD, usually you're starting to see these kids present with symptoms anywhere from as young as 3 to 4 years old. Typically, they're getting diagnosed when they get into school age, so 5 to 6 years old, depending on the severity. Inattentive type ADHD, these folks tend to get missed and you may not really see them be diagnosed until they're hitting middle school. So you're looking at about age 10 to 12 when they're more likely to get referred to a primary care physician or a psychiatrist for evaluation. And this tends to happen because as you get into middle school, the academic demands on a student, they change a lot. And so you see them really fall off the curve compared to their other 5th grade classmates. And that's when they start to get noticed. They're failing a lot of things. They're not completing their work. Their homework is always a mess. And that's when teachers will also start to recognize, in addition to the parents, that, something needs to be looked into. So it's just easier to miss because they're not creating much attention for themselves.
And then a quick follow-up. You did mention that for the inattentive subtype, it can be more difficult to detect, because if they're just sitting quietly, not being disruptive, then maybe, others will not raise as much of an issue about this. Do you feel like this is perhaps one reason why ADHD is possibly underdiagnosed in females, because they tend to be more inattentive rather than hyperactive?
Absolutely. And I think it depends on how vigilant teachers and parents are as well. If you have a person who's sitting quietly, isn't very disruptive, but don't just do very well on their work, I think there are various other things that it's easier to chalk up to than ADHD. Oh, they're just distracted. Oh, they're not interested in the work. Oh, they're focusing on something else. It's a bit easier to say it's not a disorder than it is when there's no larger disruption at play.
Yeah, and I guess the last question that comes to my mind for the subtypes or these sort of different clusters of symptoms is, do you notice that one of the subtypes of symptoms might have like a different course during adolescence or childhood versus the other, or do they kind of progress similarly? So I guess what I'm asking is, do you notice any changes in like hyperactivity or impulsivity versus inattention? Is one of them more persistent than the other? Or are they about the same?
Sure. So there is a fairly well understood sort of progression of ADHD symptoms over the timeline. When you're looking at combined or hyperactive type, usually in younger kids, and as you get older, the hyperactive symptoms are the first to remit. So you tend to see really hyperactive kids at 4, 5, 6, 7. They tend to calm down quite a bit. They can stay in their seat a lot better. They don't blurt things out as much as they get into high school. But the inattentive type symptoms tend to be a lot more persistent and are the symptoms that are most likely to persist into adult ADHD as well. So you don't necessarily see a quote-unquote improvement overall in the purely inattentive type ADHD, because those are the symptoms that are most likely to persist. But when you have a really hyperactive kid who now in 10th grade or early college is able to sit still and not blurt out answers, that's when people feel like, oh, there's so much more progress, even though some of those underlying inattentive symptoms may be just as present at that time as they were when they were 5 or 6 years old.
Okay, so we've been talking about ADHD, and obviously we've been talking about ADHD as something that presents very early in children. So myself, I do have a background in genetics, and I mean, this is not a perfect rule in any sense, but typically disorders that happen very early in life tend to be more genetic versus disorders that happen later in life. So kind of bringing this back to ADHD, how much do you think genetics versus environmental factors play in developing this disorder? Because many studies show that it is highly, highly genetic. Some studies suggesting as high as like 75% heritability. But on the other kind of flip side, other studies show that things like poor nutrition, lack of exercise, lack of sleep, and even additives in food. So I believe there was a study that showed that food coloring can cause at least ADHD-like symptoms. So how do you make sense of this? Do you think ADHD is more genetic or more environmental, or a little bit of both?
I would have to say I think it is a little bit of both. I think it's difficult to ignore some of the studies that have pointed to such a high level of heritability. If I'm not mistaken, there were some twin studies done on ADHD coming to this conclusion of such high heritability, which in my opinion is a fairly, I think, well done study to look at the impact of environment versus genetic makeup. So I'm inclined to believe the theory on very high heritability. However, I do think we also can't ignore some of the factors that you just mentioned, Dr. Wang, that there are environmental factors that absolutely play a role. how they play a role and whether that is affecting the severity of the symptoms or the course of illness, I think are still requiring a lot more research. But I think it is clear that there are factors at play. I do think, and I have anecdotally heard from parents, that nutrition affects how their kids' behavior unfolds. Red dyes specifically tend to be one of those food additives that parents will point to directly, saying, I notice a big difference. Sugar is also one of those things that parents will absolutely say, my kid with ADHD does much worse when they have high sugar foods, and so they reserve those for special occasions or times where maybe they can allow their kid to be more disruptive. And so I think we have to be mindful of those factors as well. We, as a society, I think, have become very dependent on quick fixes for various disorders, not just mental health disorders. And I think the easier solution is to take a pill. ADHD medications are extraordinarily effective, which I think is a double-edged sword when it comes to the management of ADHD, because folks will put all their eggs in one basket as, let's just do a medication, it works, and they don't want to try any other more potentially long-lasting and natural approaches that can be very effective as well. So I think we have to be mindful of those environmental factors and starting with changes in a lifestyle and considering medication if symptoms are not improving enough in combination with lifestyle changes. I think we're not going to get everybody where we want them to be with medications alone.
So in speaking about some of the genetic things relating to ADHD, what do you think are some of the possible neurobiological differonces and some of the underlying pathophysiology in patients with ADHD? So things that have been mentioned include poor frontal lobe function, executive function, potential dysregulation in dopamine receptors like DAT1, and even something like a failure of the reticular activating system.
So I will be honest, I can't tell you a lot of details regarding those. I know there is a general sort of belief of this low dopamine hypothesis, which is why folks look at medications like stimulant medications as being so effective. That this disruption in dopamine is sort of a cause and effect with the inability to focus and the hyperactivity symptoms that are seen. But I also can't speak, I think, well enough on the topic with much more detail, kind of beyond those basics, that because medications seem to work and support that when you increase dopamine, people do better, this theory of a low dopamine sort of status in the brain has been fairly widely adopted.
All right, so why don't we bring it back to some things that are more clinically relevant now. So maybe we should have talked about this even before, but how do you screen for ADHD? So what are some of your go-to questions that you ask and some of the things that you do look for when trying to decide if a patient does have ADHD or not?
Absolutely. So there are two parts to this. You have your validated screening tools, and there are a handful of them. The one I most commonly refer to is the Vanderbilt scoring. It is a free assessment that is available for parents, also available for teachers. And then you have a more structured tool that is something that is not available to the general public, which is your Connors testing, which sometimes schools will be able to do, but they ask a very similar set of questions as your Vanderbilt does. So that tends to be my go-to screening tool. And I use that in combination with what I see. If you have a kid with hyperactive ADHD or combined, typically, depending on the age and across the lifespan, it usually is something they cannot control. So over the course of a 30-minute appointment, a 1-hour appointment, you're going to be able to visually see some of these behaviors. They can't sit in their seat for the duration of the appointment. They're touching everything in your room. They're visibly distracted. So you have to use your eyes as much as your ears when parents are telling you what they're noticing and the kid is telling you what they're experiencing, and then you put it all together. The challenge with ADHD is that it is often diagnosed based on just one subjective report, which tends to be the parents. And most of the time, you want to believe that parents are very reliable sources of information, but parents are also very biased people when it comes to their children. So I think you want to be ensuring that you are getting collateral information. And the DSM requires that you have information from 2 independent sources. For kids, 90% of the time, that's going to be school and that's going to be home. It's where they spend majority of their time. So I think a lot of times ADHD gets diagnosed with just information from one setting, which majority of the time tends to be the parents. And I think we are running into a situation of over-diagnosing ADHD because we're not getting the adequate collateral information that we need. And we are following the subjective report of the parents too much, which again, I don't want to say that parents are wrong because a lot of the time they're not, but they do view their children in a very different way than other people might that are able to be a bit more neutral. So I think we want to be mindful of that. And now I've lost my train of thought of your initial question, but hopefully I've answered it.
I think you definitely answered that.
Okay.
Yeah, we were talking about the screening and you did, I think, a pretty good analysis of that. But one aspect of it that I was curious about, and a student actually asked me this recently, and I had no idea how to approach the question, but is neuropsychological testing required or definitive? What is the role of neuropsych in the diagnosis of ADHD?
Neuropsych testing can be very helpful. It is not required for the diagnosis, but I think it can be very handy if you have a case that is difficult to tease out. The challenge with ADHD and why all of our screening tools, despite being validated tools, all come with a little bit of inaccuracies. Because it's a purely subjective form, your neuropsych testing takes a little bit of that subjectivity out of it by making some tests a little bit more performance-based. So, for example, a lot of the times if a kid is doing neuropsych testing and they're testing for ADHD, they're going to do something that's called a CPT, or a continuous performance test. That essentially is a child sitting in front of a computer and letters or numbers are going to pop up on the screen, and they would have previously been told every time the letter B and the number 7 pops up on the screen, I want you to hit the space bar. So it's allowing them to engage in a specific activity that is measuring their focus at that particular time. So it turns what is usually a subjective report into something a little bit more objective and data-based. Neuropsych testing usually also encompasses testing for other disorders like anxiety, depression, autism. Kind of depends on the scope of what you want the neuropsych testing to be. And because there can be so much overlap between other diagnoses and ADHD, neuropsych testing really helps to differentiate between the symptoms and where they might be stemming from. A lot of times, folks might attribute their inattentive symptoms to ADHD, but maybe there's an underlying anxiety disorder that more likely explains their inattentive behavior. Maybe they've been through really severe trauma, and that explains their hyperactive behavior. So you want to make sure that your root cause is accurate. And oftentimes, ADHD gets labeled as that root cause when it may not be entirely accurate. So neuropsych testing is very helpful in differentiating that if the provider has any concerns about whether this really is ADHD or is it coming from something else.
You actually already hit mostly at my next question, which was going to be about differentiating ADHD from similar presentations. But to kind of go further with that, does anxiety symptoms resulting from the inattention have different characteristics than what you would see in a primary anxiety disorder, or similarly with the mood symptoms that somebody with ADHD might have, if any?
So yes and no. There is definitely an overlap where it can be very hard to say this type of inattention looks more like anxiety inattention versus ADHD inattention. They can look very similar, which is why it gets so difficult to be 100% accurate on root causes. You look at the bigger picture again, right? You're looking at the symptoms, you're looking at the context, and you're looking at the overall diagnoses for particular anxiety disorders or ADHD, and you're seeing where do things fit best. There may not always be a best answer, but there's usually one that looks like it fits a little bit better than others. So no specific, I would say, presentation of anxiety or depression or focus problems that look different based on the disorder. But that's kind of what makes things so challenging.
Yeah, and it sounds like what you were saying earlier is in those fringe cases or unclear cases, that's when you would be considering neuropsych and things like that.
Absolutely.
Now, let me throw another concept in to even further muddy these waters. So we've been talking about ADHD, largely at least, throughout this podcast as something that is a part of child psychiatry. And it certainly is. But adult ADHD is now being increasingly diagnosed and treated. The DSM itself requires symptoms to be present before the age of 12. But I think the problem is maybe a lot of people did not get adequate screening when they were younger. Something else that comes to mind is, we live in America. Well, Dr. Roy and I grew up in Canada, actually, but both of these countries are very diverse. It is a country of many immigrants. So, for example, my parents, they're immigrants themselves. When they were living in a foreign country, ADHD was not something that was necessarily socially accepted. So even if they did have ADHD, they wouldn't have gotten adequate screening as a child. So I wanted to ask your general opinion on adult ADHD, especially how valid you think it is, and how to kind of tease it out if the patient wasn't diagnosed in childhood.
So I think adult ADHD is a diagnosis that is fairly controversial within the world of psychiatry. And I think there are reasons for that, stemming from maybe misdiagnoses, overuse of medications, secondary gain from diagnoses that play a role in why this controversy exists in the way that it does. My personal opinion about adult ADHD is that it exists, but as with childhood ADHD, it is overdiagnosed. I think we are jumping to the conclusion based on one subjective report of the adult, which is the exact same problem that we see in kids, where you're relying on one source only that is biased towards themselves or the child, and you need to be able to validate that. The challenge is, how do you do that in an adult? Can you go back to the parents? Can you go back to a teacher? Can you go back to an employer? Those become very difficult things to do that are also very time consuming to do and generally doesn't get done. So you're referring to a screening tool for adult ADHD, which is a subjective report from the patient alone. And that is the only tool we have to say yes or no to the diagnosis of ADHD. So I would maybe summarize that by saying I think it exists, but we need to create a more accurate method of diagnosing. I don't think right now the tools that we implement provide a very realistic understanding of the true prevalence of adult ADHD.
Awesome. So I wanted to move a little bit into treatment. So I was wondering, looking at the main classes of medications with the stimulants, the non-stimulants, the methylphenidates versus the amphetamines, I've heard sort of conflicting schools of thought of people who say, maybe you should start with what have lower dependence potential in the form of the non-stimulant medications and then go to the stimulants if things are worse, versus people who say the stimulants are the most effective and we should be starting with them to limit disability. I was wondering what your kind of view was on what our strategy should be when it comes to pharmacotherapy in ADHD.
So I think stimulants, they are the gold standard. They are the most effective treatment that we have. I absolutely believe that. I will caveat that by saying, I think when you have very, very young children, so typically age 3, 4, 5, I would be cautious. There are long-term impacts on growth that can be a result of stimulants. We know that stimulants can affect appetite. So I think there are some potential long-term consequences that if we can avoid in a very young individual, we would want to. There also is only one medication that is FDA approved below the age of 6 that is a stimulant. So I think if you're going by the book of FDA approval, you are very limited in what your options are for a stimulant as well. So you probably are going to explore other options that are not a stimulant. But every medication comes with its own side effect profile. Non-stimulants have their own risks as well. So there's no safe, 100% safe medication, but you're kind of weighing your risks versus benefits and alternatives when you make that final decision on going the route of a stimulant or not. But for me, it's pretty clear. If you have a kid above the age of 6, I think stimulants are the treatment of choice. I will caveat that by stimulants above the age of 6, except when you start to get to adolescence and you start to run into the realm of concerns with substances or diversion or misuse of stimulant medications. That's when you start to kind of enter a different thought process when it comes to prescription of stimulant medications.
All right, that's pretty clear. And we'll definitely be going into the specifics of the different medication options in future episodes as we cover ADHD more thoroughly.
Yeah, and I think that was a very productive conversation. The last question I had was, what can parents, guardians, or caregivers of patients with ADHD do best to support their children?
I think being vigilant on the symptoms. However, I think being able to view the symptoms through a lens of what's appropriate development is also really important. That being said, I do think having enough understanding, perhaps, of what your threshold as a parent is for behaviors is really important. And I think that's why you see some families, they'll bring a 2-year-old or a 3-year-old saying this person needs treatment, whereas you might see other families where their kid might have been struggling for 6, 7, 8 years, and now they're bringing you at age 10 or 11 because the parent's ability to tolerate the child's behavior directly impacts how soon somebody might get treatment. And that's where schools can also be really helpful in saying, hey, maybe you should or shouldn't be getting this person evaluated. So I think parents being able to understand what their ability for tolerance is, being aware of what's developmentally appropriate as far as behaviors and symptoms go, and then certainly getting them to the adequate person for an assessment if they are concerned that symptoms are present. I think that's certainly, the first step in getting into treatment. But as I said before, medications are a portion of treatment. So I think there is a role for the parents and the families to also assist the child in ways that are not just based on medications, helping them come up with organization strategies, helping them have more of a regular routine, helping them through homework in a way that's more structured for how they're going to work. And maybe that means taking multiple breaks throughout their homework for their attention span that they have, that they can be most productive in. So you're kind of creating an environment to make the child more successful, implementing strategies that are not just take this medication every morning. And I think that's also going to set the child up to be more successful as they get older and into adulthood, that they have strategies that are not just medication-based, but strategies in how they organize their day and how they function around the work that needs to get done that will make them much more successful as adults and young adolescents as well.
Now, I imagine it's pretty similar advice, but do you have any specific strategies you found yourself lending to teachers who might be encountering multiple children with ADHD in their classrooms that you've heard of or seen beneficial, or any other just kind of words of wisdom?
Yeah, so for teachers, they have a little bit of support if they have IEPs that they can put into place at their school, or an individualized education plan, which is, kind of a arsenal of potential services that a child may or may not be able to qualify for based on their diagnosis and severity of their symptoms, but more sort of simple tools that can be implemented can be as easy as putting the kid either in the back of the classroom if there's less distractions, or the front of the classroom if they need that more frequent redirection from the teacher. It can be as simple as scheduling for a particular kid. If it can fit within the time frame of a test, we're going to give you a 2-minute break every 30 minutes or 15 minutes, whatever the time frame might be, so you can take a break, walk around, get some of your jitters out, and then come back. And so it can be smaller things, but the challenge with the school is you're typically going to be viewing this as a service to a child if you're allowing it to be to one individual and not to the entire classroom. And that's when you start to enter the world of school-specific services like an IEP or a 504 plan. If some of these more simple strategies of sitting them in the front of the classroom, or, allowing them to wear headphones that dampen the surrounding noise that every other kid doesn't have the ability to do, then you have to kind of go down a different path of creating a specific plan for them.
Awesome. Yeah, thank you, Dr. Roy, for all of the advice so far and everything, and the answers to the questions. We've really grilled you today. But,
no problem.
Do you have any final thoughts or myths that you would want to dispel, or just anything kind of weighing on the topic of ADHD that you want to give?
Probably what I said earlier, that I think we have to view the symptoms as a whole and not as individual symptoms. I think we have to check ourselves as to what is developmentally appropriate, what is outside of your norm of being inattentive, of being hyperactive. Everybody's going to experience these symptoms over their lifetime, but when is it considered pathological? When is it reaching the point of needing a medication or needing to see a psychiatrist? And I think we have really started to blur those lines of what is considered appropriate, and the threshold is becoming increasingly lower and lower across schools, across parenting abilities. And I think we need to maybe kind of revisit that and be more conservative in our approaches with medications and consider the environmental and lifestyle changes that can be implemented as well.
All right. So I think that just about brings this episode to a close. I just wanted to thank Dr. Roy again for coming on and providing us such valuable insights into ADHD. Coming up next, we're going to be talking about the different medications used in the treatment of ADHD. So this includes things like the stimulants, such as methylphenidate and the amphetamines, as well as the non-stimulants, such as atomoxetine, viloxazine, the alpha-2 agonists, like clonidine and guanfacine, and even some of the obscure medications like modafinil. I also wanted to give a quick shout out to one of our listeners, Kendra, who is a psychiatric physician assistant. And she actually emailed us a couple of weeks back requesting this topic, and we were happy to accommodate. So if you're a longtime listener, feel free to email us at psychroundspodcast@gmail.com and feel free to put in a suggestion. Thank you once again for listening to Psych Rounds Podcast. Have a great rest of the week and enjoy the weekend.